Hello, everybody. Welcome to this webinar of Foxy, and I thank Doc Mode for giving this opportunity and the Foxy for giving this opportunity. So today we are going to talk about the medical management and the surgical management of myoma. This is where I come, and I'm from Hyderabad, the city of pearls, and then I know most of us know each other, so I thought we will just directly go ahead with the program. So this most of the times when we all do this myomectomy, whatever is left over after the uterus, many times an anesthetist comes forward and asks us, why are you keeping that uterus, madam? It is of no use. You can as well remove the uterus after you remove 30 fibroids, 40 fibroids. But remember, whatever is left over, the uterus has the capacity to become a normal thing and give a property of reproduction again. So it is not us who is going to decide what the patient needs. It is a patient's choice. Depending on that, we make a call about the treatment. We take into consideration the age of the patient, symptomatology of the patient, and the choice of the patient whether to reproduce or not, to retain the uterus or not. So let me ask ourselves some questions whenever we start treating something about the commonest disease called myoma. One, what are the needs of the uterus that we need to keep back the uterus to its normal place? Second, what do we know about myoma and when to treat? Management of myoma and AUB, and management infertility, and how to go about if it is in the menopausal syndrome, and what are we trying to look at? And the controversies and the recommendations and guidelines. So the need of the uterus is: one, regular menstrual cycles; second, the reproductive function; third, supporting the ovary for hormonal harmony. So these are three things we have to keep into our consideration when we think about the type of management you are looking at. And what do we actually know about myoma? One, it is the most common tumor of the uterus. It is seen as almost as 80% of the people will be having, especially in the late reproductive age group. After menopause, it usually comes down. Worldwide, that is the commonest cause of hysterectomy. And as far as parasitic myomas are concerned, in the recent times, courtesy our minimally invasive surgeries, we have started seeing more and more, and it is identical to metastasizing leiomyoma. And leiomyosarcoma, which is the most concerning thing right now, is it is a rare form of cancer, what we have to understand, and accounts for about 5 to 10% of soft tissue sarcomas, which themselves are very, very rare. So National Organization of Rare Diseases says that uterine leiomyosarcoma is an extremely rare, which is estimated to be around 6 per 10 lakh women in the US each year. Average age of diagnosis is 51, and the survival rate as such for leiomyosarcoma is 40% in 5 years. So doing all this, when do we actually treat? First and foremost, always look at the symptoms. If they are symptomatic, whether it is pain, AUB, pressure, or fertility, or obstetric issues, or heavy menstrual bleeding, anything, and it is symptomatic more than 12 to 14, progressive increase in size, all submucosal fibroids should be treated. What does ACOG say? One main difference between ACOG and the rest of the guidelines would be that if the apparent myoma is of significant concern, that is, it is affecting the mental health, we are right to operate on it. So knowing these things, when to as far as classification are concerned, we follow Figo-Coles classification. And then for the hysteroscopy, we have to follow the European guidelines of ESGE, depending on the acute and obtuse angle. The symptoms, depending on the presentation of it, it can be the bleeding or the pressure effects or the infertility, how it looks. And imaging, we just do the ultrasound is the first line of treatment. And if it just shows that this imaging is the right way, TVS is better than anything. If we still have additional modalities, we can go for 3D ultrasound or MRI. Since the pathophysiology, one main thing which made a difference towards our management and the treatment is now the knowledge of pathophysiology, that it is not the estrogen, but is the progesterone and the progesterone receptors, along with the genetic factors and the disturbance of aromatase function, which is the most significant factor. So knowing this, the whole management of the medical management has changed its way of the way we look at it. So progesterone and its receptors hence represent the potential targets to which we have to target, so that the treatment based at target-oriented management of the fibroids. So what we need to remember, it is not the estrogen, it is the progesterone and the progesterone receptors and the genetics, along with it the disturbance of the aromatase function. So this is the flowchart on which we have to make a decision for the treatment. One, whether it's symptomatic or asymptomatic. Second, perimenopausal, postmenopausal. Postmenopausal, we have to do a DNC and then take a call. And if it is premenopausal, she wants to retain uterus, retain fertility, then comes whether it is medical management or surgical management. So we'll directly going into the management part of it, because that is a topic of concern right now. So current medical management which we have, like I said, target oriented, that is selective progesterone receptor modulators like ulipristal, mifepristone, lisinopril, and telapristone. So how do they help? They help reducing the size and reduce the bleeding. They are directly act on the anti-angiogenic factors and anti-proliferative factors. The advantages are we can retain the fertility, symptomatic relief is very good, and we can actually prevent the surgery, especially in the perimenopausal age group, and prevent the recurrence after surgery. So what I would prefer using SPRMs would be around the perimenopausal age group, and also post-surgical to any smaller seedling fibroids which are there to prevent the recurrence of the fibroids. So it downregulates the growth or angiogenic factors and suppresses the neovascularization. The dose is 5 or 10. They did not make much of a difference. So 5 milligram per day. The exact schedule is something which we are going to talk about next. The preoperative also we would be usually giving. So how do we use it? Long-term intermittent treatment is what we are looking at. That is 3 months, 1 month gap, 3 months, 1 month gap. This is the way that cyclical schedule is done. That is like well-known recommendation. When we start using ulipristal, we have to know one thing, that is PAEC, that is progesterone-associated endometrial thickening, which we usually see, which is like a cystoglandular hyperplasia, but nothing to be worried. Once we stop the drug, it will shed by itself. So we should not be worried when ultrasound shows a thickened endometrium when the patient is on ulipristal. For a preoperative treatment, we use a single course of 3 months. And for medical management, we are using 4 consecutive courses of the intermittent schedule. That is 3 months, 1 month gap, 3 months, 1 month gap, 4 consecutive courses. So one thing which we all have to remember when we are looking at ulipristal, or the reason why the SPRMs have gone out of vogue or literally banned from the European market, is that the liver damage and the 8 cases of liver dysfunction which has been reported by British journals. So baseline LFT is advised before starting the treatment, and in between each cycle, once we finish one cycle, we have to repeat. The time that there is twice the upper limit of normal, we have to stop the treatment. So the important point when we are using ulipristal is to do the LFTs, and pre-op we just give it 1 course, and if we are going for medical management, it is a 4 courses of 3 months, 1 month gap. Like this is the difference between the GnRH and SPRM, whereas GnRH acts at the pituitary level, SPRMs act at local level, that is fibroids, endometrium, and pituitary. So it is a multi-targeted, so the outcomes would be better, and patient outcomes would be definitely better. So long-term intermittent therapy would definitely decrease the size in the volume reduction to almost 67%. And this, there are many studies in the recent times which have come out which said that there is improved quality of life, reduced bleeding, and higher rates of amenorrhea, which is what we have to be counseling the patient when they are on the ulipristal. So these are all the Pearl studies, which is one which made a difference to us. So what are these studies? First, Pearl 1 study has told us that ulipristal definitely helps. Pearl 2 study said, in comparison with leuprolide acetate, it is of same effect with better side effect profile and can be used for longer duration. And Pearl 3 is it's for long-term treatment, and Pearl 4 is between 5 and 10. Is there a difference? No difference. So now we come up with this treatment, medical management, that is long-term intermittent SPRM treatment. If there is a good response, we can stop the treatment and wait for the nothing to be done and wait for recurrence of symptoms. If they come back, then we will assess what to do. But if there is insufficient response in the term of volume and bleeding, then we go ahead for the surgical management. So what to expect when we are giving therapeutic management? It brings their bleeding under control, amenorrhea in 79%, shrinks the fibroid in 49%, reduces pain, and improves quality of life. Pre-op, when we are giving it, improves the anemia, and during surgery, planes are not lost. We do get the planes, but there is central necrosis or softening which happens, which makes the retrieval of the fibroid difficult unless we put it into the in-bag. So all the biopsies which are done showed irreversible and benign changes. So it is recommended pre-op and intermittent treatment. This is the way we have to go about when we are looking at ulipristal acetate. Coming to GnRH analogs, we do know about the hypoestrogenic state it causes and the decrease of leiomyoma, which is temporary, that there can be a rebound normal size of leiomyoma. So it can be used in the pre-op to reduce anemia, reduce the intraoperative blood loss, and to increase the post of hemoglobin and to decrease the post of complications, which is of useful, especially because it decreases the fibrosis. Following treatment of GnRH, this thing prior to the surgical myomectomy, 35% reduction of size would be there. So surgery might actually help us in decreasing the blood loss, and the size in the morcellation also would come down. Cochrane review says, yes, 3 to 4 months prior to the fibroid, if you do it, it decreases the volume and the size of the fibroid. But always remember that the plane is something which is lost. But triptorelin with letrozole, this is the latest study which said that it definitely decreases the mean size volume by almost 70%, and this combination significantly decreases the operative time and the volume of fluid absorbed, especially in submucous myomas. So this has a great future. Probably we can look at one dose of GnRH analog with letrozole of 2.5 for at least a month before planning for submucous fibroid, with the outcomes being good. So hysteroscopic myomectomy and hysterectomy to decrease the volume, GnRH can definitely be used, but usually not recommended for conventional laparoscopic myomectomy because of the possible loss of planes. But if you are used to doing it, please go ahead. And because of side effect profile, we cannot use more than, especially in Indians, not more than 3 cycles. Otherwise, it can be given for about 6 cycles. Coming to aromatase inhibitors, in perimenopausal age group, especially, this has a huge advantage because it inhibits the conversion of androgen to estrogen, and it is letrozole of 2.5 milligrams, and it tremendously decreases size and volume. So it is for 3 months, that is 12 weeks. The myometer size has 50% decreased by using one course of the letrozole. So pre-op decreases the blood flow and the time required for hysterectomy we would always get, and the anemia also can be corrected, and operative time also is much decreased. But as of today, there's much more to be got and to understand the importance of aromatase inhibitors and the age group at which we can be using. But definitely can be used submucous fibroids before the surgery, 1 cycle before surgery. Cabergoline. The minute we knew that in the center of the fibroid we have the production of the prolactin, we know that cabergoline is going to be effective, because prolactin is secreted not just by pituitary but uterine cell and can act on myometrium as a growth hormone in the form of autocrine and paracrine. So using that, when we use cabergoline in a study, it is seen that comparatively, definitely size of the fibroid and the duration of bleeding with significant benefits can be seen. So, but we always have to remember the adverse effects of cabergoline which might be there, and out of the medicines which we have, either depending on the patient that she does not want a surgical option, then we can give her the option of ulipristal or an aromatase inhibitor or a cabergoline. So contraindications are something which we cannot forget, that is cardiac valve disorder, pulmonary, pericardial, retroperitoneal fibrotic disorders, hypersensitivity to any ergot derivatives, uncontrolled hypertension, and liver function. Again, don't forget that. Next comes not exactly medical, but medically tried and minimally invasive procedure, that is a LNGIUS. It has been used, tried, tested for a long time, but it cannot be used for submucous fibroids, intracavitary lesions. Other than that, any other case where patient is not stuck with the size of the fibroids, but only menorrhagia, symptomatic response, it can be decreased. The size of fibroids also come down by 30 to 40%, but there are no RCTs which are evaluating it. Other drugs like OC pills, tranexamic, NSAIDs can be used for any symptomatic treatment of menorrhagia, but danazol is definitely not recommended because of side effect profile. Now that we know about medical options, we can, depending on the age, if it's a reproductive age group who want to conceive, we do have ulipristal which we can give, or we can always think of anastrozole or even cabergoline for 3 months, especially in the fertility trying patients. In the perimenopausal, again, we have anastrozole plus GnRH if it's a short term, or pre-operative, we can still look at ulipristal or anastrozole and even the GnRH analog. So next comes the surgical options. What do we have? The commonest reason for hysterectomy is myoma, and that is the permanent treatment. Second, we have myomectomy, depending on laparoscopy or open or hysteroscopy. Other techniques are myolysis, that is with electrocautery, which during the surgery we can do it, or laser or cryo, and embolotherapy, that is uterine artery embolization, and other methods like MRG, FUS, that is, or a HIFU, and a thermal ablation, it's only symptomatic, which we are looking at. So strategies are hysterectomy. Like I said, it's a permanent, and for the symptomatic fibroids. In an asymptomatic fibroid, we can still go ahead and do hysterectomy, especially after menopause, the size is increasing in size and there is a suspicion of malignancy. And vaginal laparoscopy depends on the skill of the surgeon, expertise, facilities, and the patient's choice. And myomectomy, when a woman wants to preserve the uterus, which should be the treatment of choice, especially for fertility conserving and for the other reasons of heavy menstrual bleeding, pelvic pain, pressure, and reproductive issues. Hysteroscopic myomectomy is the first line for whenever there is a symptomatic intracavitary fibroids. Lap myomectomy is preferred over abdominal because of its advantages, which we all know. And pregnancy post-lap, when can we suggest? We usually plan around 3 months after the myomectomy. There are growing concerns regarding morcellation, so which we all know regarding of the incidence of the spillage of the leiomyosarcoma, if at all if it is present, but there are no accurate methods to diagnose. As we'll talk about the controversies in the last, the current recommendation is contained morcellation, with a proper counseling of the patient about the power modulation. So it should be judiciously used. The surgery per se. What do we do? Pre-op? Yes. In our routine practice, we just do one night before the procedure, we would be giving a low molecular weight heparin, and then liquid diet, clear liquid diet for 24 hours prior to the surgery, and nil by mouth from the prior night, and then antibiotic prophylaxis. I would be talking about laparoscopy, minimally invasive myomectomy, not the open surgery. It would be the same principles because we are going to reproduce the same thing what we learned in the open technique to be done in the laparoscopy so that it can be reproducible. So GnRH analog can be given like we all discussed for a very large uterus and severe anemia and when we need time prior to the surgery. So standard positions, trocars would be the same dorsal lithotomy of 30 degrees flexion at the thigh and 30 degrees flexion at the knee joint and abducted legs. And during anesthesia, absolutely no to the nitrous oxide because it causes intraoperative bowel distension. And ETCO2 is a must. We have to monitor the CO2 monitoring, and then 2 TV monitors, surgeons, first assistant, second assistant, and we have the trocars, primary, secondary. We will go ahead with Foley's, and then regular uterine manipulator is what we use. That is the elevator or a sound. The instrument should be very, very clearly put on the table. Right hand with the minimal instruments, which would be a lap needle for vasopressin, and bipolar if we have to do it, and monopolar hook or spatula dissector, which I will be showing us, which is a specific instrument which we use, scissor to cut the suture, and suction irrigation, needle holder, knot pusher, and oscillator if necessary. So let us go through the videos which. So this is our technique of doing
primary port is a supraumbilical port.
I would be
where curvilinear incision is taken.
Yeah, so primary port is what we are doing. That is a primary supraumbilical port is our favorite port. The reason being that most of the additions are below the umbilicus and the Fannin steel incision. And by doing the supraumbilical port, it is cosmetic because we go just above the curvature and we do a modified Hassan's technique, which is that we open till the rectus sheath with the knife, and then from there when we are opening the peritoneum with the artery. So this is a custom made rod which we have, which has a conical end, which is then inserted into the trocar is then driven onto it. So if you can see it, this is an open technique, so the chance of not entering or blind sac is not there, and we are directly entering into it. By doing a 2 centimeter above it, we have the extra 2 centimeters, and additions can be preferred, and my technician can be left for there. If the 1 centimeter is the incision, if we need onto the rod, we can cut little more for that. And now you can see the trocar which is being screwed over the rod. So once that is done, we are inside and we literally have 0% complication rates with this because it's a blunt trocar, and left lower port is 2 centimeter above and medial the anterior superior iliac spine. The main thing what we have to avoid is that inferior epigastric and superior epigastric. So under vision, we would be doing as little as everything we should be looking at, and upper left, upper ipsilateral port would be lateral to the rectus muscle. Once we are lateral to rectus muscle, we are avoiding the superior epigastric. So once we go inside, we see the first step which we do is infiltration of vasoconstrictive agents. That is 20 units of vasopressin in 500 ml of normal saline. And then that is injected between the myometrium and the capsule. Any plane you can do, you can go all around or a single point or into the myometrium. Next is incision, which can be a vertical or transverse or oblique. I would prefer an oblique because we can avoid the fallopian tubes on both the sides. So once a little incision with unipolar is given, I use my favorite instrument, that is the harmonic, to extend the incision. So it is almost like vertical but oblique, so suturing could become very easy. So when we are doing an incision, if we are having a contralateral port, then it has to be a vertical incision. If it's a transverse or oblique, ipsilateral incision. We are all being the ipsilateral surgeon, that would be a better thing. So next step would be the enucleation by traction or contratraction. It is being done by traction is by myoma spiral, and contratraction is this instrument which I call it as dissector. Dissector is like a crowbar spatula which goes under it, and on the ribcage when we are pressing against it, it is just enucleated. You can see with the ease with which the whole myoma is being enucleated from the capsule without any bleeding. We hardly use any hemostatic agent or using any energy source. So our technique of myomectomy will not be needing any only bipolar as and when is necessary, because it is a mechanical traction and counter traction technique. So this is a technique which we are using. So we go there, you can see the spatula is then being put in between the capsule and the myoma, and it is being enucleated from all around. If necessary, we use the harmonic, and then this the capsular fibers are then, extra fibers are then cut. And if the fibroid is big, we have the changing myoma technique, myoma spiral technique. So we change and get it nearer to the crowbar technique so that the physics acts better. So when we have that, it is a traction of the myoma spiral and counter traction of this spatula dissector, what we call, will completely enucleate the myoma. So this is the way the whole myoma is being enucleated. Then there will be no bleeding inside. Then we use the barbed suture. Because of the barbed suture, the suturing has become, life has become very easy. We have 1 or 2 layers depending on it, baseball suture or even continuous, what we can do, because post that we can always put a layer of interseed or surgical for the hemostasis plus the adhesion prevention. So we go 2 layers. One is for the depth of the entire thickness, prevention of hematomas. We have to make it not too tight, just tight enough for hemostasis, not too tight for the necrosis. So we have large curved needles with either 30 or 40 millimeter is what we take. If you have interrupted sutures, you take Vicryl, otherwise it will go for barbed sutures. So you can see how it has been done. So rarely we will have to use any energy source. Suturing, like I said, one is a larger stitch which goes deeper, and then one more superficial. And now in bag, or it is a contained morcellation, what we are looking at, the needle will always be convexly towards the sacrum. So here it is the in bag, we are entering into it. So I think this is a bigger one which we are showing. So we put the whole fibroid inside the bag, then under the thing, we have to do a morcellation inside the bag. So this is the way we are looking at, but is it necessary that we'd have to do all the cases in bag? Or definitely it is preferable to do a contained morcellation, but is it mandatory to do in bag, or it has to be removed? So that is what we are looking at here. You can see the bag is now being completely removed with the little material which is left over. So we don't have to go back and then keep searching for it. When the morcellation, when we are doing it, the purpose is to transform the ellipsoid myoma into a cylindrical one. And this is like electromechanical morcellator which we use. It is a continuous movement of the forceps at a constant speed is what we are looking at. So this is the technique. When I said the rod is there, we automatically, it can, how many ever times we can just enter into the abdominal cavity without worrying. So always, when we're using morcellator, it has to be always into the field of the vision. So at the end, I will never forget not to put the interseed after irrigation and after everything is done. So this is how the interseed is placed on the suture material, which will be there in place for 28 days. So by that time, the barb suture is also interiorized into the thing. Barb suture is viable for about 180 days. So now let me go back to my PowerPoint presentation. So where is the next? I think next is also a video. I hope it runs. Okay, this in the previous one was a contained morcellation, which I showed it into the bag so that we can just keep a bag open, and inside it you put and do the morcellation, take the morcellator into the bag and do it. So probably if you have time, I would definitely love to show the contained morcellation, which has to be the need of the day today. And this is for the lower uterine segment. When a woman comes to us with the pressure symptoms of obstruction of the urine, when you go inside in emergency and see, this looks like a broad ligament which goes, and then when you open it, always remember UV fold should be the first one to be cut and pushed down when it is a lower uterine segment fibroid. So anterior lower uterine segment fibroid, when you take out the UV fold and go, it looks as if the whole fibroid is there. But the dictum is there is always a capsule. So the procedure should be the same. Give the installation of the vasopressin first thing into the layers. At any point, you can give it at multiple points, you can give it anything. The least resistance place, the liquid will be going. So the dilution which we use, it can be 20 units in 200 ml or 100 ml, but definitely should not increase the anesthetist should be told before, and it should not increase the 0.3 ml in per 100 milligram per ml of the blood concentration. So this is the way it goes. Myoma spiral is then going in between the capsule, hold against it, traction of the myoma spiral and counter traction of the dissector, which is our favorite instrument when we use this. So by doing this technique, you can actually see most of the time in the broad ligament and even the lower uterine segment fibroid, how much ever we try to take it out, then it actually deceptively will look smaller. And then when we take it out, it is actually a bigger fibroid which comes out, especially in the broad ligament fibroids when we are doing it. There, you see, this is the area where we are always worried because there is uterine there and there is always the ureter there. But by being inside the capsule, not going out of the capsule and using the mechanical traction, counter traction, you can clearly be very, very safe away from the uterine and the ureters, and you will not be having any, after the decompression is done, you will not be having any fear of any ureter or the uterine coming. Always close the dead space using the, like I said, 2 layers of the bath suture or the interrupted sutures. And if necessary, in lower uterine segment, you can cover the UV fold, or you can leave it and put a interseat or a surgical on top of it. If you are using any bath sutures, I would definitely prefer to cover it with a layer of the sheet of a interseat or a thing. So this is how it will look, and the modulator would be the same thing. So next, once we have finished, this is a this is a case of doctors again, which will come. The reason which I'm showing this video is that subserosal, the way we do is different than this intramural fibroid. So when it comes to subserosal fibroids, we would not want to have a redundant tissue. So we would go all around. So this is a doctor, ophthalmologist, who had come to us with bleeding PV because there are 2 fibroids here. One is subserosal, one is the intramural 3 to 4 centimeters. So here again, vasopressin. Ipsilateral is the way we are doing. The vasopressin is given in the center, which can take care of both the places, or you can actually give it in both the fibroids separately. So that's being given. Vasopressin is being instilled. Like I said, the dilution is about, I use a dilution of 20 units in 100 ml, but we started off using with 40 ml, 100 ml, 200 ml, and then we give 100 ml right now, and whole of 100 ml is given, but anesthetist should be ready with atropine when necessary. That is how we have to look at. So now the incision is being ready to be given. I use a unipolar spatula, which is my favorite thing, but you can use hook or directly the harmonic. Now here, we have to take care of the fallopian tubes because infertility is something which we are looking at. So 1 centimeter to 1.5 centimeter away from it, you go all around and then cut. So once a little incision is given with this, I always go around with the harmonic because it has the best action of coagulative cutting. So I go around all this using harmonic. So once the redundant tissue is removed, our way of suturing becomes easy, and the next follow-up scan will not show an extra tissue showing that probably remnant fibroid is the report which usually they would be giving lot of stress for even the patient and the treating physician. So redundant tissue to be removed, and whenever we see any feeder vessel, we think there is a vessel there, that is when only we go selectively with the bipolar or energy source to buzz it off. Otherwise, in most of the cases, we never have to use any energy sources in this mechanical traction, counter traction techniques which we use for myomectomy. So it is very good for any infertility patient because the healing is better, no necrosis, and so it's the rupture of the uterus is as good as in any other case because the healing becomes absolutely normal. So once this is done, all around, the remnant tissue is being cut. There will be regression of the normal fibers back into the uterus. We will not be wasting any tissue when it comes to intramural, whereas in subserosal, the redundant tissue is taken away. So again, like I said, traction, counter traction using a myoma dissector by the crowbar technique. The fibroid is being elevated there. So this is the technique which we use. Rest of the things is all the same. So I'll be going to the next video because intramural we have already seen. Now I think this also I will have to go into the main thing. Where is the other one? This one. So where is the broad ligament? Next is broad ligament video. Yeah. So this is what I wanted to show you. One thing about broad ligament videos, broad ligament fibroids is that it looks deceptively small, first point. Second point is it looks as if it is in continuation with the lateral uterine wart, which is usually the common thing. But what is important is the presses on to the lateral pelvic wall. So the ooze is going to be more, and there will be the retroperitoneal space, a loose areolar tissue, which we are opening up. So post-operative collection is also going to be more. So, and small oozes, it's something which is not there. If it's a smaller one, fine. If it's a bigger one, you always should be having a thrombin coagulant with you in the OT when you're doing such a procedure with the broad ligament fibroid like Surgiflow or something like that, or TCL. So again, like I said, first thing is UV fold. Get the bladder back down to its place, especially when there is a previous segment, previous cesarean. Use a lateral window technique or a central window technique, and then push the bladder down. So once you see this, once the bladder is being pushed out, then put the thing. And we will not be looking at capsule when it comes to broad ligament, because that's not where the capsule will be there, because it will be coming from the adjoining myoma. So look at the way it can be taken away and twisted. This is one of the simplest broad ligament fibroids. Vasopressin is given, and all around the way it is arising from the broad ligament, it is being enucleated, and here the additional fibers are being cut using the harmonics. But what I said is, what we have to remember with broad ligament is the lateral pelvic wall and the ooze which can come, and the vessels which it develops in the parasitic circulation it takes from the lateral pelvic wall. So always be careful about that, and always suture this particular if it is nearer, and the pressure of it on the ureters. So always have a look at the passage of the ureter. And one more point of concern is, never give an incision from posterior when it is a broad ligament fibroid, because ureter is always the posterior layer of the broad ligament. So incision is something in the broad ligament we would always prefer to give in the anterior layer of the broad ligament, and then enucleate it. So if this is intact, if you can see the posterior layer intact, ureter is almost always intact, and we're pushing the bladder down and the UV fold is being pushed down, the ureter is lateralized and it just goes. Do we have to put a stenting before the surgery? Not necessary, because if it becomes rigid, it is very difficult to lateralize the ureter. But if it is supple, by doing the small maneuvers of pushing the bladder down, the ureter gets lateralized. So you can always have a look in the at the end of the procedure at the level of the pelvic brim for the ureter, and then see how it goes. And then always, like I said, it's always the in-back morcellation which we usually use. Put it inside the, yeah, okay, I think I'm happy that we are able to see the contained morcellation here. Contained is when you put the whole fibroid inside this bag, and the morcellator goes into the bag. And we don't have to struggle with keeping gas inside it and all that. This is just that morcellation is done inside the bag. So it is contained into the bag, and later we just catch hold of all the edges of the bag and then take out the whole of the bag outside layer, you can see. So once the whole bag, morcellation is done inside the bag is now being closed, and the bag is held and taken out from this. So like I said, in the end, always look at the broad ligament and see from where. Don't try to meddle too much into that. And this is the interseed which we are putting, which we make it a habit for all the fibroids, and whenever we have any barbed suture which is there. So let us now go back to our PPT. So next one is the round ligament fibroid. So round ligament is, yeah. Right, round ligament. Most of the time, if you look at this is the small uterus which is there. Fibroid, the scan tells us it's a 28-week size, and then when you put our hand on the abdomen, it is 28-week size. But so deceptively, the whole uterus is fine, fallopian. But in this round ligament, when you're doing, be careful about the fallopian tube, which is going to be behind. And again, always approach it from anterior side and never from posterior side. And this time, when we are doing this, always be closer to the myoma and not closer to the uterus. So if you take care of all these three things, and if by chance you're cutting the whole round ligament, you need to suture it back, because that is something which is very important for the anchoring of this uterus. So this is what you have to look at, and then the rest of the things is almost similar to. And most of the time, the parasitic supply of such huge fibroid will be there from the omentum, and you need to be separating that. Then the next myoma would be TLH, posterior cervical myoma. Posterior cervical fibroid is what, again, the last video which I'm going to show. So again, this is the patients, again, they'll come with obstruction and then pressure symptoms. So rest of the hysterectomy would be the similar, the way technique which we use, that is cutting the round ligament first and then the other side, and then uterines, then coming back. And when you're near the uterus, even in the fibroid of the child, you give a vasopressin there. Decompress it, because when it is cervical fibroid which you are doing, your vault cutting would become impossible for you to use unless you take out and decompress the fibroid. So this is the cervical fibroid. With the same technique, never master the technique, whichever technique you master, just apply it. So it is always the installation, enucleation, traction, counter traction, and you can see that loose cellular tissue which is wasted here, and this is the fornix which is there. And then we go ahead and finish the hysterectomy, and then the specimen is then retrieved. So this is these are all the various presentations which we have seen. And the next, when it comes to the factors which influence morcellation, we've been talking about lots of controversies about the morcellation. Tissue resistance is very important. The more calcification it has, it takes some time, and myoma volume is important. Cannula diameter, torsional stress is very. People just pull that specimen and think that it is not coming. We should not be pulling the specimen, because it's the resistance which leads to problem. Extraction, other techniques we should be knowing how to do it. That is posterior culdotomy and large port, that is endobac, and mini laparotomy to remove the thing. Lap myomectomy failure rate is going into open is 0.34, total complication is 11. When I say that, it is minor, major is only 2.2. Risk of uterine rupture is 0.26, comparable to that of open technique. Pregnancy rate is as high as 80 in our series, but it is 67 universally. So vascularity comes back within 6 weeks to normal. So recurrence rate is, when they say 21, it is because there are smaller ones which we forget, we are not this thing. The GnRH has been given, and smaller ones are indistinguishable in the surgery, and then they come back. Possible drawbacks would always be the learning curve and surgical expertise and specialized equipment which we need to know. So tips for any surgery would be master the technique and repeat it every time. And mapping ultrasound before will tell us exactly how many fibroids are there and how many we are going to remove. So give a vasopressin or hydrodissection. Learn mechanical traction, counter traction, and less energy sources, and use MAB sutures, so that we are not here to prove something. We are here to give a best result to the patient, and hemostatic agents if necessary, selection of morcellator, and finally interstate. Why is interstate? This is a case where I have removed about 28 fibroids, and during cesarean hardly any additions. This is and more where I have removed 14 or 18, I don't remember how many, but anyway, this is the way the uterus looks when the cesarean is being done. And after the interstate, if seeing is believing, this is the second look which we did after removing 20 fibroids. You look at it when we put the interstate, and second look, there is absolutely no addition. Then we know post myomectomy in the open surgery, the additions are a norm. So don't forget to use that. The other surgical techniques is UAE, uterine artery embolization. But when the patient wants to preserve things, and way back in 1998, 99, when we did a few uterine artery embolization, we were not happy because it is being done by a radiologist, and then they come up with extrusion of fibroids through the uterus, and the complications have to be dealt with us. So the patient's choice. But now we have HIFU and MRJFUS. Again, that is technique span sensitive, and ACOG recommends, yes, it is an option which we have to think of. And these are various results which came up with HIFU, which says yes, complications are the same, but shrinkage is very good, as much as 50%. Symptom improvement is also very good in 92% of the cases. But it is technique sensitive, associated with bowel injury, also in 0.0148%. But again, like we said, it is post-operatively only we will know the complications. So we should be knowing, learning, getting trained, and then only do any procedure. And 78 patients conceived after HIFU, that is 71% live birth, that's good enough. So especially in fertility, preserving surgery of non-invasive, if the patient insists on it, the HIFU is one of the alternatives you can look at. So GC recommends, yes, but remember one thing, you need MR if you're doing MR FUS, it is one fibroid at a time, and we cannot do nice says very clearly, not more than 5 uterine fibroids, and they should be more than 45 symptomatic, and no fibroid, I mean the fibroid size should be less than 12 centimeters. And there should not be any pressure related symptoms, but is there the proximity to the bowel or the bladder. So for fertility, when it comes, we know submucous fibroids are the ones which we are tackling when it comes to fertility. If there is distortion, yes, we are removing it. But if there is distortion is not there, also there are so many data which say that anything more than 7, please remove it. 5 to 7, there's still no data. So for pregnancy, when a patient comes, try medical treatment. If there is good response, perfect. If there is no response or insufficient, then go for surgery. The same way, no desire for pregnancy, give medical response. If there's good response, stop treatment and wait for the symptoms to come back. Whereas when they want pregnancy, immediately after, when there's a good response, treat for fertility. And if there is insufficient response, then go for myomectomy. This is a series of pregnancy for medical management after ulipristal. And for submucous fibroid, okay, back to our videos. So we have submucous fibroid. Yep. The thing about hysteroscopic myomectomy is always that you can either use a mechanical morcellator, which is MyoShave, or the Smith and Nebu's technique. It's a beautiful one. Again, you can use, and this is when you're using a normal saline bipolar resectoscope. The one thing we have to understand is it's always we have to come inside, start from the other side and take it from above downwards, and never try to enucleate totally. That is because it will start rotating inside the uterus and not knowing it. And when we start taking from above down, there will be protrusion of the myoma back through the capsule into the cavity. So we will have to remember that. 1 second, the PowerPoint has gone. Let me open that. Yes. Give a second time. I know today I'm being little. This thing, no, wait, please don't do anything. I will do that. Right. So when I say menopausal syndrome, if you don't, and if you end up doing a hysterectomy, we do know that many of the patients will be ending up with menopausal syndrome. A twofold increase in ovarian failure was approximately 14.8% of the patient with hysterectomy, even if we save the ovary. And it will come at about 2 years earlier. And within 4 years of the surgery, 54.3% will have menopause. So we need to take a call and go in favor of medical or uterus preserving surgeries. So a lot of controversies regarding this. What to do with all these morcellator problems caused by this thing, like risk of severe trauma to the tissues. And next slide. 1 minute. Next slide. Where is it? It's not going. The same slide is repeating, Ma. Yeah, thank you. So severe trauma to the tissues is one of the first problem which is going to cause by porcellation. And the second is tissue dispersion, which we are not interested. That's where the whole thing comes. Spread of endometriosis, adenomyosis, leiomyomatosis, which is less serious than the malignancy. And the next is increased incidence of parasitic leiomyomas. Again, the reported incidence of 0.1%, and serious dissemination of occult malignancy, that is 1 in 200 to 1 in 1,000 as far as FGS is concerned, quantifying the risk to 1 in 350 based on the report. An unexpected pathology coming up and we don't even think about it. And the other thing would be not all pathologies can actually have a serious prognosis. So against, I think there's a lot of evidence which started coming up, a lot of litigations which came up, and lots of studies which said morcellation is the cause for upgrading, and these negatively telling about the chance of unexpected sarcoma and all that. Does it mean that we should stop? Can we go to next? Yes. So that is, does it mean that we should stop using morcellation, or is there anything else which we can do it? The solution to the problem, given the occult risk, does not make sense to stop the procedure completely. So that means that we are going into for invasive procedures, leaving the non-invasive. That would be a step in the wrong direction. So we should adequately counsel them, predict preoperatively, no reliable test, but we can do an MRI, LDH, and age risk, and then proceed the MRI if there is a lot of necrosis and lysis inside, and then take a call about how to go about with it. So solution to the problem, FDA came up with a bag that is the pneumoliner, but still it can leak, spread of leiomyosarcoma. What we have to understand is once we give an incision, because it is hematogenous or even the lymphatic spreads, once you cut it and put it aside itself, if we are upstaging it. So what we do not want is spreading it into the cavity and having a going in. So contained morcellation should be the way of going forward. Very active placing the myoma itself means that we are upgrading the disease. So it is technique sensitive and it is avoidable. Most of the times we can do it. So despite FDA caution, ACOG says, yes, we should do it after informing it. It should be an option which should be discussed with it. So controlled morcellation either through the abdominal or through the vaginal morcellation, which is again can be through the bag and put in the bag and get the bag through the vagina, is something which we can do. There are no many other techniques which have been given, that is intracorporeal electromagnetic, future directions in the form of having a prototypes of having retracting mesh and putting the fibroid inside it, where the mesh itself will have an activated wire which can just crush it and use it. But by the present situation should be a contained or in-bag morcellation. So recommendations of SOGC of Indian would be asymptomatic, leave them alone, individualized, and according to your expertise, you go ahead. Hysteroscopic should be first line for submucous fibroids. Surgical planning is important with the mapping, and morcellation, talk to them and then do it. And SPRMs and gonadotrophin is a better medical management as of today, and during surgery you can give vasopressin, bupivacaine or epinephrine. Uterine artery occlusion in a selected patients is what. So we came up with key practice points of fibroids in India. That is where we all came up and said risk factors is something which are there. FIGO and ESG systems should be there. Pathophysiology has changed our understanding, and pelvic ultrasonography should be a must, and hysteroscopy and MRI and ulipristal is very effective, but LFT should be done, and GnRH analogs are not recommended before conventional laparoscopic myomectomy because of possible loss of plane, and current evidence is insufficient for aromatase inhibitor, and Langi IUS can be used. Hysterectomy as a permanent treatment is what we are looking at, but myomectomy should be the option, and hysteroscopy for submucous, laparoscopy for otherwise. Pregnancy to be planned after 3 months, and current recommendation about the risk of morcellation to be discussed. MRG FUS is an option which can be given. So finally, the algorithm, depending on symptomatic, asymptomatic, and patients wish to retain the uterus, retain the fertility and the age, and then take a call. So to conclude, before we take the questions, get the uterus to its need. That is for the normal menstrual function, reproduction, and avoiding the premature menopausal syndrome. So asymptomatic, leave them alone unless it is a major concern for the patient. Individualized treatment, surgical planning, and morcellation, discuss. Intercede should be utilized especially as a barrier, addition barrier, and because it decreases things. Thank you. Now I think I would be going ahead with the questions. So Sutavasan, prolonged Nagarcoil, prolonged amenorrhea after SPRM, how to manage? Yes, Sutha, that is what is going to happen. Keep a watch on the ultrasound picture. If there is a PAEC, you can do a DNC and leave, but otherwise just leave them alone. Within 4 to 6 months, they would be usually having a withdrawal bleed. Otherwise, you can give a plain progesterone and estrogen plus progesterone and have a withdrawal bleeding. Tanmay from Mumbai says, tranexamic acid recommended dosage is about 1 gram TID. So it is about, we have to go about 1 gram of tranexamic acid 3 times a day when their bleed is bleeding profusely for about 3 to 5 days. But progesterone or a hormonal treatment is a must when we are treating the hormone receptive tumor, that is fibroid, Tanmay. And Ruma, if myoma size is less than 5 mm and we are giving this thing for Febipress, myoma reduces to 1 mm, can we continue the medicine? First of all, anything which is subcentric, that is sub 1 centimeter less, does not need any medication at all, including except for the location, depending on the location. When we take a call, depending on the size of the fibroid, age of the patient, and location of the fibroid, unless it is submucosal, 5 mm and anything less than 1 or 2 centimeter need not need, unless we think that is the cause for the fertility or the bleeding which is happening. So I think in your case, Ruma, you will not be needing any medical management for this patient. And management of symptomatic ultra fibroids should consider if there is a hysteroscopic solution. Yes, if it is anything less than, see, hysteroscopy, as long as we are concerned, type 0 should be done only hysteroscopically. Type 1 type of fibroid, it has to be still hysteroscopy depending on the size. Anything more than 3 centimeters should be laparoscopy, but less than 3 centimeter can be dealt with hysteroscopically. Type 2 fibroids and above, it has to be laparoscopic myomectomy. But again, type 2 when we say, or type 0, depends on the expertise of the particular surgeon, and then only you take a call. And when we talk to the patient, we always counsel the patient that it can be a 1 sitting or 2 sittings that we have to do it. So do as much as you can, and then you can always give if you find that fibroid is very big, you can always give a GnRH analog, or you can try GnRH plus letrozole for a cycle before doing the surgery, so you can have a smaller size to operate on. Dr. Archana Arvind, which drug is better, ulipristal or mifepristone? Definitely ulipristal is better because we are dealing with receptor modulator there, and the outcomes and the results are well studied with ulipristal than with mifepristone. Pinky Rajan, side effects of any side of etiological treatments. Etiology is the way we live. That is why medical management, any medical management will definitely have a side effect. So it's always tol, mol, ke, bol. If you are using carbapenem, you should know what it can cause. We are giving ulipristal. We are only worried about liver function and the test. And if you are using GnRH, we are worried about the bones and even with anastrozole, we are again worried about the bone and the vitamin D deficiency, demineralization. So you should, and also GnRH and anastrozole, you are worried about the menopausal symptoms which the patient can, and the hot flushes which they can present with. And Hima Bindu, 29, unmarried, noticed heavy bleeding for a few months and checked in with multiple 4 to 5, largest 5 into 5. Definitely, it has been 1.5 months since came to know. Now, if you have 4 to 5 fibroids and the patient should deserve a surgery or should demand a surgery. So you're symptomatic, you need it. You're unmarried and you're for fertility, yes, you need it. So you want to go in for a medical or surgical. First, if it is medical, you have to know that it is not going to make fibroids disappear. There will be reduction of size of fibroids to about only 40 to 50% at the most. If it is GnRH, it's going to be rebound. And if it is going to be the regular medicines, it will be about 30 to 40%, which is going to be coming out. So definitely you are a candidate for surgery. And how long can you wait? Depends on your symptoms of pain or hemoglobin or how much you are going to bleed. Next, Priya from Kakinada, how safe is ulipristal? Like I said, I usually leave it for perimenopausal when patients go and do their scans and come back with 2 centimeter asymptomatic fibroid or 3 centimeter asymptomatic fibroid and they're worried about the fibroid is the time when I give it. Or post laparoscopic myomectomy, I do not want any small subcentric ones to come back. I would treat. These are the 2 indications which I use in my personal practice. But one thing, LFT is a must before doing, and after giving ulipristal also LFT is a must. We have not seen any LFT derangements in our patients who have received it, but theoretically there is a risk, so be careful. And then even if one report comes abnormal, just stop giving the medicine. And thank you, Dr. Archana, for your compliment. And Sindhu, the schedule of carbapenem and letrose. Letrose is 2.5 milligrams for 3 months continuous, and even carbapenem is 0.5, just the way we give weekly ones for about 3 months. And does the above said medical management applies to adenomyosis too? What we need to understand about adenomyosis is that the pathology is, even whether it comes to, it is definitely aryl hydroxylase, which is at as the problem there. It is the progesterone receptors which are there. MRFUS and HIFU will definitely work, but ulipristal, the studies are not there. GnRH helps temporarily, like because we can give only 3. But I feel letrozole aromatase inhibitor might have a very good role even in adenomyosis, but more and more trials have to be done. Aduna, history of left suprarenal carcinoma, current multiple size in a 50-year-old PSO is indicated or not. In a 50-year-old woman, definitely with a history of a carcinoma before, if there is again a family history also to super added with it, I would definitely go in for a BSO after giving her the understanding about the menopause syndrome and the need for HRT if necessary, or if she says that she would be coming up with regular follow-ups with the ovarian Dopplers and regular CA125 and HE4. If she doesn't want to remove it, I would still respect her. But my personal opinion, at 50-year-old woman with the past history of left suprarenal carcinoma would be PSO. So there was some tips to operate on lateral wall fibroids. Like I said, lateral wall fibroids, 2 things. One, ureter, how much it has pushed and how deeper it is towards the lateral wall. That is the going into the pelvic floor, because a lot of there will be a parasitic supply, blood supply which comes there, and a lot of capillaries which will be there. So always give vasopressin and always give incision anteriorly, never on the posteriorly, and use mechanical traction, counter traction to remove the thing. And after you completely elevate the separate the whole fibroid and elevate it from the point of junction, that's when you need to separate it from the lateral wall. And the suture the lateral wall and confirm that posterior layer is intact and the ureter is intact. Or you can always do a post-surgery cystoscopy to see the ureteric jets. That is what you need to do. Dr. Alpana, at what gestational age should we do elective cesarean? I would do it after 38 weeks because with our surgeries, we are not worried, but we had many cases who had gone for vaginal deliveries also. So it is not necessary, but it is, like I say, it is always technique sensitive. If you're good enough, good with your technique of suturing, good in tight enough, like I said, tight enough to cause hemostasis. There's no dead space inside, no hematoma formation, not too tight to cause necrosis. That and the healing is going to be so perfect, they can still go in for, and the cavity is not been entered, you can still go. But as far as cavity is not being entered, I always have it this thing because I am little aggressive surgeon. I believe that when you are entering and taking out a baby, you are entering the cavity. You still give a trial vaginal delivery after that. So I always think that cavity entering, not entering should not be an issue, but the other things have to be close monitoring, and having a double setup is what is an issue. Ram Kumar, I give vasopressin, like I said, 100 in 100 ml 20 units, but recommendation should be 200 ml 20 units. Actual recommendation is 400 ml 20 units, but I would give it in 100 ml 20 units with because our anesthesiologists are well versed and they're not scared, and they're really, and then we never give it into the vessel. We take care, and then we inform them before going in and then giving it to them. And criteria for doing HIFU, like I said, it should, number of fibroids should be less than 5 and never more than 12 centimeters, no pressure symptoms, but this should be a symptomatic patient. And these are submucous, we usually will, and also we can do it. This is a thing, few things you should know, and you should learn the very focused this thing is put there, the surrounding tissues are spared. 1 centimeter submucous in infertility, any submucous, if it is type 0, you have to go and remove it. If it's infertility, it has to be removed. So for submucous fibroid, first line of management is hysteroscopic removal. Thank you, Sindhu, for your compliment. Alpana, very nice. Thank you again. Dr. Bharti Devi, 35-year-old with completed family with multiple fibroids, symptomatic. Can we go ahead with surgical? Yes, but like I said, if she's symptomatic and the choice of the patient and the age of the patient, we would go ahead and do a myomectomy here, not hysterectomy, because she's only 35 years. Sitavasan, experience in myomectomy scar pregnancy. We never had myomectomy scar, but we did have cesarean scar pregnancies quite a bit because of the, probably because of the previous cesarean scars are thin, and when we do the surgery, there will be a small lacunae which would be there, which forms a suction and effect on the pregnancy, and it goes into it. So we just have to do laparoscopy and then open and take out the complete pregnancy and clear the edges and then resuture the scar. That's it. Even if the myomectomy scar, like I say, myomectomy is the surgeon dependent, technique dependent. So it depends on how you do and what you do. Don't blame the technology or the technique if you are doing it in the wrong way. So you master your technique and do it. Would like to know more about hysteroscopic myomectomy, expecting future lectures. Hopefully, definitely, Sindhu. If given a chance, we would take a hysteroscopic myomectomy as another class. Prashanti, how to manage cervical fibroid. You just saw a video which I showed about cervical fibroid. Cervical fibroid, one thing is, depends on. If it is exteriorized into the vagina, it's much more simpler. Just give the vasopressin if necessary and hold it with a sponge holder and rotate it. The more you rotate, that from the base, it gets enucleated and comes out. So it's not coming into the vagina or into the uterus, and it is actually exteriorizing and causing the pressure symptom. It has to be laparoscopy. We need to cut open the cervix. The rest of the technique is the same. And then you remove the whole fibroid and then suture back the cervix and back. So decompressing, and here with cervical fibroid, there are two things you have to consider. One, the vessels and the ureter again, where it is going to push it back to the side. So always be in the center, never go lateral. Give the incision in the center, traction and the water traction from the center. So if you stay as away from the ureter and do, that is definitely a way to go forward. And always use a vaginal obturator when we are doing cervical fibroid, either in the using gauze or on a stick, or even any obturator which you use. Zohra, thank you, Zohra, for compliment. And Sindhu, 33-year-old, heavy menstrual bleeding with adenomyosis, 14-week size, no effect on ossipils, and Mirena. So if there is no effect of Mirena, I mean, adenomyosis is one patient I really have this thing on, but recent times we have good results coming up with MRFUS and FUS. Maybe you can try it out. And there is a danazol treatment which people have started. I think my personal opinion in this case would be you can try aromatase inhibitor for 3 months. If that doesn't work, think of HIFU for this particular case. We have to save the uterus. Early surgery. Thank you, Usha Naveen from Nizamabad. Thank you all. I think I answered all the questions, and it's a peace talking, and thank you, Foxy, for giving me this opportunity. Thank you, Doc Mode, for this opportunity. Thank you all. Hope to see you all again.